Well, good afternoon, everyone. I think we'll go ahead and get started. If there's anyone who has not yet muted their phone, that would be greatly appreciated, and you can unmute if you have a question for Dr. Heil or any of the other faculty. My name is Barbara Zarowitz. I'm an affiliate professor at University of Maryland School of Pharmacy and also a senior advisor for the Lamy Center on Drug Therapy and Aging. We're very, very pleased to have you attend. I guess it's close to the end of our scheduled webinars with faculty office hours. Most of you have come to these with great insights and questions to share with the entire team, which we appreciate immensely. The lecture that Dr. Heil gave a couple of weeks ago was on antibiotic allergies, and it was just packed full of good information, which if you're like me, you go back to your desk and you sit there and you think, oh, I should have asked her this, I should have asked her that. So this is our opportunity to ask Dr. Heil or others on the phone who are faculty attending, just what other issues or questions you have related to antibiotic allergies, as well as antimicrobial stewardship in general pertaining to programs that you're putting in place in your facilities. We have received one question. What suggestions do you have for dealing with multiple, possibly inaccurate records of beta-lactam allergy in the EMR for facilities without a policy, without a protocol, without a process in place for evaluation and testing of these allergies? Dr. Heil?
Thanks, Barbara. Can everybody hear me okay?
Yes.
Okay, great. I think this is a good question and definitely something that a lot of places are facing. So I think ideally, in an ideal world, you would set forth a formal process to evaluate and test your, to reevaluate all of the patients in your facility that are currently admitted for their allergy status, and then have a firm process moving forward to do this in a more streamlined or standardized fashion. But I think this actually makes a really good project, like a QI project for an eager student pharmacist if you've got someone rotating through your facility or any potential nursing learners that maybe are coming through, to go back through all of your residents, look at their allergy records, and identify the ones that do have a penicillin allergy listed, and go do a bedside interview with those patients to try and see if you can elicit a better allergy history. Although it's a very different practice setting, we're trying to pilot something very similar at University of Maryland Medical Center with student pharmacists in our emergency department. So we've got a group of pharmacy interns that are working within our emergency department to do patient medication histories, and as part of that process, they have a short allergy history questionnaire that they also go through with the patient, where if the patient does state that they have a penicillin allergy, it will prompt the student pharmacist to ask further questions to try and clarify that patient's allergy history to improve our allergy history documentation. So it's one of those things that it would certainly be time consuming up front to go through all of your currently admitted patients, but if you establish some sort of process after the fact where any new admissions to your facility had a standardized questionnaire that was asked of them and their allergy history documented based on that questionnaire, moving forward, you would know that you have the best allergy history possible for all of your admitted patients.
Thank you, Emily. Great question and good answer. And I'll remind everyone, the chat feature on Zoom is at the bottom. If you just hover over the bottom, you can open the chat icon and ask anything that way if you would prefer not to speak orally. So we're happy to have you participate either way. A lot of questions come up, Emily. I'll just ask a couple as we wait on other participants to chime in. But a lot of times when you look at electronic health records, what you find in the allergy field, and this is somewhat of what the last question addressed, you really find more drug side effects listed in allergy fields. I think that's a problem because electronic health records haven't gotten a good answer for where to record adverse side effects that patients experience with with medications. And antibiotics are often implicated in just troubling side effects rather than things that would really interfere with therapy. But I mean, what are your suggestions on that? Is there a thought about how these should be addressed? Should they be recorded somewhere else? Is there a plan, if you know, within EPIC, which I believe is the system that the university uses, or if others know about point-click care or matrix care for addressing the separation of adverse drug events from side effects and allergies in their recording?
Yeah, that's a great question. So I know within EPIC, we do have the ability within the allergy field to select whether or not it's an allergy or an adverse effect. So it would still populate the patient's allergy banner, and it would still show up on their allergy list, but you're able to choose the designation of adverse event instead. One of the downfalls of that, of course, is that, for example, if you're a pharmacist verifying a medication, or potentially a nurse getting ready to go administer a medication, or a physician getting ready to place an order, that will still generate a flag if there is a potential contraindication from the computer standpoint. Based on what you're ordering, it will still pop to the physician or the pharmacist or the nurse to say, oh, this patient has an allergy. And you'd have to actually take a moment to read to see that it's been designated as an adverse event instead. So I think some of it might depend on what the actual severity of the adverse event was, because there are certainly things that don't count as true allergies, but are severe enough that either due to patient preference or based on what happened, you certainly would not want the patient to get that medication again, in which case I think documenting it where you document your allergies is appropriate, and just making sure it's designated either through like a free text comment if there is no official adverse event selection option as being such and not being an allergy. But that being said, if it's something potentially like nausea, vomiting, GI upset, family history of allergy that the patient is insistent on having documented, then those are things that I think could actually cause a little bit more confusion than anything if placed in the allergy record itself. And that might be a situation where potentially if there's another place within the medical record, maybe even like the patient's past medical history, you could enter it as just something of note to the patient's history that might work out better.
Thank you, Emily. Maybe we could ask the participants on the phone, anyone who uses point-click care, where you record ADEs or allergies in your system, and then if there's anyone with matrix care as well. We'd love to hear from you. Dr. Sheikh, can I call on you if you happen to be on? I know you wanted to join today, but if you're on, is there a place within your facilities that these kind of things are being documented? She may not have joined yet. I wanted to ask the participants on the phone another question as you're sort of formulating your own. What do nursing home staff need in order to help distinguish adverse drug events from allergies? What would be the most helpful kind of information?
My name is Tina Bracey, and I work at one of the Future Care facilities that uses PCC. And in PCC, we have the ability to put allergy. There is no distinction between adverse reaction and allergy. So I think what would be helpful is a clear definition of allergy so that we can educate the staff what to put in that slot.
That's great feedback, Tina. Yeah. Emily, did you want to comment on that as well?
Yeah, I guess, Tina, would you mind describing a little bit more for me what fields are available? Like, do you have a comment field or anywhere where you can free text, or are you limited to certain drop downs or certain parameters within the system?
Well, we have drop-down boxes that we use. And so when we're in a resident profile, we can click into it. It does allow us to put allergies, but that's it.
Okay, so there's no field to like classify the severity of the reaction or what the actual reaction was?
Right.
Oh, that's unfortunate.
Now, it will say allergies, it'll say type of allergy, it'll say category, reaction type, and there is something that says severity, but most of the time, that field will say unknown.
All right, well, I can tell you the definitions that we've educated our staff on. We do have similar fields within our allergy history. One of the things we do have, which is really nice, is a comments field where you can free text more information. So I'm sad to hear that you don't have that option, but for the reaction type, if there happens to be something listed as intolerance, that is the one that we use to represent an adverse effect. They also have one that says side effect within our dropdown that might also be better suited to represent an adverse effect versus an allergy. And then for the grading system for severity, we suggest low severity for a mild rash, medium severity for hives or a severe itchy rash, and then severe for anything that was remotely related to anaphylaxis, so difficulty breathing, throat closing, tongue or facial swelling, or if somebody had more of a dermatologic type hypersensitivity, like immune complex reaction, like a Stevens-Johnson type syndrome, we also would list that as severe, of course. And so I don't know if you have anything other than low, medium, or severe, but we don't use a severity category for the adverse events. So we'll usually just put the agent, the reaction type, we'll put side effect, and then we won't code a severity. And within the comment box, we might type out like patient experience nausea, does not prefer to take this medication, or something of that nature, just to get at a little bit more detail as to what happened.
That's helpful. Thank you.
Sure. And is there anyone on the phone who's using Matrix Care? Is there something similar that we could share with everyone? Okay. Other questions or comments? Dr. Sheikh, I think you have joined in the interim, and I would love to hear how you are handling things like the differentiation between allergies and adverse drug events, and just managing through that whole process in your facilities.
So good afternoon, everyone. So as Tina just spoke from one of the future care facilities, in PCC we have a template to enter the allergies, but there are only few boxes. So it has the category allergen, allergy type, severity, reaction type. There's a special note that can be entered, which is free text. But I think the challenge remains is that some residents may have history of allergy, and it may be from a very distant past that may be carried from, chart to chart, document to document, and we may not have clarity what kind of rash was it. So sometimes residents may not be capable enough to remember, or family members may not even know the exact reaction to certain medications. So it's certainly a challenge. But I like the idea that if we know that it was just intolerance, maybe nausea, or some other mild side effect, then we can maybe capture it in the reaction note. So the free text box that we have here.
Thank you. Thank you. Other thoughts or questions related to antibiotic allergies?
Barbara, I'd be curious to know from the group if anybody has done anything proactive related to allergies within their own institutions that they would like to share. Don't be shy. I'm sure there's a lot of people that have done some great things, or if anybody has ever referred a patient for allergy skin testing as an outpatient to help address a patient's allergy. For those that have maybe thought about it but never done it, I can speak from family personal experience that you can schedule appointments depending on your insurance, usually without a referral, to see an allergist. There's a huge allergy and immunology group on the Hopkins Bayview campus for an outpatient penicillin skin test for a pretty reasonable copay. I believe my mother's was like $30 to get her penicillin allergy ruled out. So something that you certainly could be proactive on doing for patients that may be at high risk of needing antibiotics in the future if they have any sort of immunocompromising conditions or something like that.
Dr. Heil, this is Dr. Brandt. Sorry for the road noise, but this strikes me, and I'd love to get your perspective. You know, we talk a lot about medication reconciliation, right? But part of my thought is, kind of initiatives can be taken regarding allergy reconciliation. And just as we struggle with communicating that effectively to other providers and other systems, so it strikes me if we got this testing done, how would we effectively communicate that? And how could we ensure that all the systems get updated? Because it worries me about how this gets shared with others. Because what strikes me is just hearing the formats and the way we report needs attention and some education with it. But then how do we share that information with others? So any lessons learned and how we could do this better?
That is a great question, and I think that's something that a lot of us still struggle with. I don't have a perfect solution, but I can at least tell you from our own experience, we have about a 20-ish% relabeling rate, meaning if we've even successfully delabeled someone of a penicillin allergy, it somehow gets put back in the chart. I think one of the things you can really do to alleviate that is make sure you're doing really thorough education with the patient themselves, depending on how or why it is that you're delabeling them of the allergy. So for example, if they did have penicillin skin testing, really go through with them what that means, and that means that they do not actually have a penicillin allergy, and explain to them that maybe what they experienced as a child or whenever they did have a reaction could have very well been real, but we don't always maintain our allergies throughout our life. We can lose that allergic potential over time because some patients hold so tight to those allergies. It's something they've been reflexively telling every healthcare provider for so many years that, if they do go back to an emergency department and they're being triaged by a nurse and the nurse asks, do you have any allergies? It's kind of natural for them to say, oh, I'm allergic to penicillin. So really providing that education to them in the moment when you've either given them a direct oral challenge with amoxicillin, which they've tolerated, or done a penicillin skin test to which they've tested negative, to go through what that really means and to tell them that they need to remember to share that with every healthcare provider they come in contact with in the future. We also give our patients these little pocket cards. It's just like a business card size token of their testing that they can put in their wallet that explains that they've had the testing, and we ask them to share it with any healthcare providers they come into contact with. But you could even argue to do the same thing if you've just done a good allergy history with a patient. So you've talked to the patient, you've elucidated that really they didn't have an allergic reaction, but potentially they had an intolerance, they just had very bad stomach upset, and so it's a medication that they've always thought they couldn't take again. Discussing with the patient that being labeled with a penicillin allergy is not benign, and it might lead them to getting suboptimal treatment in the future, and discussing the difference between an allergic reaction and an adverse event might help the patient feel more confident in the future to not immediately label themselves as penallergic when they're talking to new healthcare providers. In the setting of not having shared electronic resources, that does make it extra hard as well, because you may successfully delabel your patient in point-click care, but the allergy might pop back in Epic during a hospital admission, or maybe that information hasn't been communicated to the pharmacist filling their prescriptions. So that's one of the situations where, depending on the patient's ability to help facilitate some of those communications, you as a healthcare provider, if you have time and are able, it would be a great thing to shoot a message to other people on that patient's healthcare team. So in our outpatient clinic where we do some skin testing in our ID clinic, there's a couple of pharmacies that we work very closely with. And so if we do delabel a patient of that allergy, I'll give that pharmacist a ring and just let them know what we've done and ask them to remove it from their system as well to try and reconcile that. I mean, I think the dream would be if we had a shared electronic medical record across all practice areas, and that could help alleviate that. But your point is very well taken, and I can tell you just from talking to other colleagues around the country that have an interest in allergy, the issue of having patients relabeled after they're delabeled is something that everyone seems to struggle with. And I don't know that anyone's come up with a great solution as of yet, but all of the education that you can do with your patients to make sure they understand what you've done in terms of delabeling them, either through just a good history or some sort of formalized testing, I think is a really important step.
Thanks, Emily. And just curious, has there been any sort of advocacy on a state level regarding CRISP? Because I know we're doing work in that realm with medication reconciliation, but again, just strikes me some of the parallels that we can learn from this.
That's a great question. I actually have had some contact with one of our state representatives, Dan Morheim, who is a physician that works at the Maryland Congress, and he expressed some interest in the work we've been doing at Maryland related to penicillin allergy. So that's a good idea of something to bring up with him, and whether or not we could leverage CRISP for this use. I think that would be a great utility for it.
Thank you.
Other questions, comments? I mean, I think one of the things that I would say, and Emily has done a really nice job of covering these points in her lecture. Those of you that didn't, were unable to attend, the slides are posted on the Lamy Center. The point of all of this is a good antimicrobial stewardship program is going to always try and direct prescribers to select antibiotics that are appropriate dose, appropriate for the indication or the microorganism being treated, the location of the infection, but then also appropriate in terms of any underlying risk factors that the patient may have that would preclude them from receiving a particular medication. So matching all of that is really an art, which is why this becomes so difficult, because it's very important to look for all of those potential variables. The bottom line, though, is we're doing this to try and protect our patients, to promote appropriate antimicrobial use, to not, as Dr. Heil had said, not to have them go to an alternate agent that may not exhibit that adverse effect or allergy, but may also not be quite as effective, or there may be higher resistance in the area to that particular antimicrobial. So these become critically important because they touch the patient or the resident directly. And that's why it's meaningful to me to have this dialogue because these are direct outcomes that can really, frankly, change the life of a resident. We've talked about mislabeling with a penicillin allergy. I can tell you of a death that was reported because there was no penicillin allergy noted. The patient did have one, and of course got a penicillin antibiotic and had an anaphylactic reaction and died. So it is critically important to have accurate information reported and not too much noise out there with things in that box that aren't exactly allergies, because it can lead to what we call alert fatigue. Nobody pays attention to the box anymore if it doesn't have accurate information. So I'll pause one more minute to see if there are other questions. And if not, we can give you some time back in your day. Anything else on your minds?
Barbara, did we want Dr. Shake to share some of her experiences recently now that she's on the call? I think we were going to talk about the flu outbreak or something.
Dr. Sheikh, yes, did you want to address what's been going on with influenza and measles in Maryland?
So yeah, I wanted to share our personal experience that we have seen a little bit peak in flu infection in few of our facilities, and what we decided as a company that we were going to extend giving flu shots to all the new residents and to employees who have not been previously vaccinated till end of April. So it seems that of Maryland, it's still the flu is still existing, but it's at the minimum level. But I just wanted to share that with everyone that even in start of April, we had seen few cases in our facility.
Thank you.
So I was, Barbara, I also wanted to extend that question to everyone in the audience if anyone has experienced such similar peak in any of their facilities.
And I believe Dr. Brandt had reported that was an issue because there was a shortage of Tamiflu also. And it makes it very difficult to short circuit the influenza in the absence of the appropriate antiviral. Comments from the field? Anyone else noticing a late peak in influenza occurrence? Thank you for sharing that information, Dr. Sheikh. Everyone is quiet on the phone, so maybe they, among our participants, it sounds like maybe we don't have any occurrence late.
That's a good thing. So
That is a good thing. That is a good thing. And no measles for sure.
This is Tina Bracy, again from Future Care Cherrywood. I do have a question I'd like to throw out to the group. If they're doing anything different in terms of having young people visit facilities because of the measles outbreak. Can you give me some guidance in terms of if you have maybe a policy for 12 and older to come into facilities because of the measles, or if it hasn't been addressed?
Tina, that's a great question. This is Emily. We actually just tackled that at the medical center. We were already in a visitor restriction policy because of the continued flu season. So what we decided to do was just to extend our flu season restriction policy sort of indefinitely during this measles outbreak. So we do not allow visitors on campus under the age of 14 unless they're coming to campus specifically for an appointment for themselves. So that's the policy that we've always used just during the flu season in general, but we've elected to extend it due to the measles. I'm hoping that we'll also advertise why we're doing that so that maybe some of the anti-vaxxer parents might catch a wind of why we've decided to limit access to the hospital with children. And I know that the LifeBridge Health Group throughout Baltimore has done the same, and they have implemented a pretty strict visitor restriction policy for children and have specifically advertised that it is related to the measles.
Thank you for sharing that.
Related to the flu, I just wanted to also add in case, I don't know if Dr. Brooks is on from the state, but there is a website from the Maryland Department of Health called Flu Watch. If you just Google MDH Flu Watch, or we can send out the link to participants that were on the call today. You can look at how many cases of the flu have been reported at the state and whether activity is sort of localized or widespread at the moment, which is helpful to know if you feel like you're seeing potentially more cases at your institution. But we are still in a widespread place right now in terms of flu activity in Maryland.
Well, thank you, Dr. Sheikh, and thank you, Dr. Heil. Great information was shared today. We appreciate the attendance of all of the participants, and we have one more webinar coming up at the beginning of May. Information will come out in a couple of weeks, but if I'm not mistaken, and Emily, you can jump in, it's related to urinary tract infection, am I right?
That is correct. We'll have Dr. Serbi-Lika talking to us about asymptomatic bacteria and how to tackle the problem of overtreatment of urinary tract infections in our long-term care facility residents.
So we very much will look forward to that. And so in advance, you can think about all your tough cases with urinary tract infection and get ready for another very informative session. Thank you all so much for attending on behalf of the Lamy Center and the Antimicrobial Stewardship Collaborative. We appreciate your ongoing diligence to improving antimicrobial stewardship in your facilities, and we hope you have a wonderful day. Thank you so much.